Hello, everybody. My name is Ryan Mehlhaff, and today I'm going to be covering mild neurocognitive disorder. And some of the things that I want to outline for today is that we really want to distinguish this disorder from Alzheimer's and major neurocognitive disorder, as it's sort of sits as an in-between disorder between those two major ones. Right. So, what is mild neurocognitive disorder? So, we have varying definitions, right? According to the DSM-5, the criteria for the disorders and the threshold of differentiating mild from major neurocognitive disorder are based on, in part, on functional assessment. And functional assessment in this regard refers to what functional abilities might mild neurocognitive disorder be impairing as opposed to major neurocognitive disorder. So, assessing what types of functionalities are being impaired by mild NCD are vital, so we can better distinguish the two. So, let me remind you, according to our textbook, mild neurocognitive disorder is characterized by modest decline in performance in one or more cognitive areas. Some compensatory strategies might be required to maintain independence. So, this is addressing the fact that there is some nuance to what classifies mild neurocognitive disorder. I might walk into a room and forget why I'm there, but we also have to remember that this could just be due to baseline cognitive decline, and I'll get into that a little bit later with the Brettner paper, but let's move on for now. So, according to Young et al. 2021, mild neurocognitive disorder is considered an intermediate state between healthy aging and early dementia, or is a potential state that represents a higher risk of dementia. So, it's the intermediary state. We've established this before. It sits between. It isn't quite there. It's just extreme enough to hint that you might be going down the path of developing a major neurocognitive disorder, but you haven't quite met those symptoms yet. So, according to Brettner, it's an opportunity for early detection and treatment of cognitive decline before patients' deficits become more pronounced and progress to major neurocognitive disorder or dementia, or another. And in Brettner's paper, they address the mild cognitive impairment is what it was initially referred to, and then the DSM-5 decided to say, no, this is a little too nuanced. We need something that's a little more finite, and what they ended up doing was they came up with mild neurocognitive disorder in their list of disorders. So here are the domains of neurocognitive disorder. We have the cognitive, we have the symptomatic and observational, and we have the assessed. These three things are what's going to break down mild neurocognitive disorder to us in a decisible manner that's really trying to cut up what distinguishes it from other disorders. And this is just a little reminder down here that mild neurocognitive disorder falls under neurocognitive disorders like major and just in general. So, the diagnostic features of mild neurocognitive disorder. We have an important mention up here, and that's that diagnostic criteria are provided for both syndromic entities, followed by a diagnostic criteria for different etiological subtypes. So, what this is basically saying is that we have to distinguish the syndromic entities and etiological subtypes. That there really is two things that can fall under, and those two things can coexist, right? So, just paying attention to that. We have different diagnoses for multiple subtypes later on that I'll cover. And so we have cognitive changes, functional activities, and exclusion of delirium. These are the major three diagnostic features of mild NCD. And so cognitive changes are abrupt changes in mental status that unwarrant evaluation of medical sources for the cognitive change, and that is according to DSM-5. We have the functional activities portion, which is in mild NCD due to Alzheimer's disease. We have impairments that increase over time and function status gradually declines until the symptoms reach a threshold for diagnosis of major NCD. That's also according to DSM-5. And then we have the exclusion of delirium according to the National Institute of Health. And I'm not sure why that cut off there, but I have the sources, rest assured, at the end of the slide. So what causes mild neurocognitive disorder? Well, there are a wide variety of etiology to mild neurocognitive disorder, and those consist of things like Alzheimer's disease, vascular disease, and traumatic brain injury. So traumatic brain injury, that's anything related to concussions. Vascular disease relates to issues affecting the brain that can lead to mild neurocognitive impairment, so things like stroke or other vascular problems. And Alzheimer's is the most prevalent cause of dementia, and it manifests as mild cognitive decline in its early stages. So those things are very important to remember. Just backtracking to mild neurocognitive disorder falling into a bunch of syndromic boxes, basically. So other etiological subtypes to mild neurocognitive disorder. Yes, there are loads. We have the three that I mentioned. We have Alzheimer's, vascular, and then the traumatic brain injury. But we also have Huntington's disease, prions disease, neurocognitive disorder with Lewy bodies, with Parkinson's, with frontotemporal neurocognitive disorder. We have HIV infection, substance medication-induced neurocognitive disorder, and neurocognitive disorder just to standalone. So, what are the risk factors to neurocognitive disorder? Well, risk factors might include substances that have built up in your brain, right? So we're referencing the Lewy bodies. If you drink heavily, if you've just built up a bunch of gunk in your brain over the years, that's going to be a risk factor for mild neurocognitive disorder. Also, not having as much social activity, not staying healthy, those are other things, and not having an orderly schedule. So things to look out for with the disorder. You're going to want to look out for changes in memory, language, attention, movement, sense of smell, behavior, and planning, right? So backtracking to, well, if I just walked into a room and I forgot why I'm there, that might not be mild neurocognitive disorder. That might be something else. That might be just baseline cognitive decline. So consulting a doctor and trying to figure out whether you're on track for developing major neurocognitive disorder, that's really imperative. And focusing on prevalence, we have 2 to 10% of adults developing neurocognitive disorder by age 65, as well as 5 to 25% by age 85. And important things to consider is that prevalence is sensitive to the definition of the disorder. So again, backtracking to nuance and how it's possible that there is baseline cognitive decline, right? And um, our baseline cognitive decline differs from person to person because that baseline looks different from person to person. So that's why we have these numbers split up. It's all different. So, are there any possible treatments? Yeah. So staying healthy, being orderly, and reading books is also proven to help with neurocognitive disorders like Alzheimer's. So, yeah. Now, interestingly, this study conducted by Huang et al. 2021 looked at neuroimaging and acupuncture. So they wanted to see if the neurotreatment for mild neurocognitive disorder worked well over time in respect to the amount of visits. Each patient would come in and either take acupuncture only, or they would go in and they would have the neurotreatment, right? So we see in this graph that over time, the more the patient visits with a combined treatment, the better their score is in cognitive functioning. And in this slide here, this is an Alzheimer's score chart. Lower is actually better. So the higher the score, the less they would remember in this case. But as they're getting lower, it's becoming better. So, and that's with due respect to more visits. So what have we learned? We've learned a lot of things about mild neurocognitive disorder and really the nuances, how it sits between Alzheimer's and major neurocognitive disorder, and that there are a wide variety of things to consider in terms of trying to get it out to the public in as clear as a way as possible. So thank you so much for listening to my presentation, and I'm very happy to have done this project for the Pay It Forward. So thank you.